Dear friends, colleagues, ladies and gentlemen, my name is David Agayan. I'm a surgeon, postdoctoral researcher at Oslo University Hospital, Rikshospital, Oslo, Norway. First of all, I would like to thank Scientific Program Committee for accepting our abstract for an oral presentation. Today, I will present one of our recent studies with the title Laparoscopic Parenchyma sparing liver resection for large colorectal liver metastases. As you know, colorectal cancer is one of the most frequent cancers in the world, and many of these patients, they develop liver metastases, and liver resection still remains the only possible curative treatment method for these patients, providing 5-year overall survival varying from 30 to 60%. And nowadays we have laparoscopic approach to perform liver resections for these patients in specialized centers worldwide. So we have two approaches, open and laparoscopic, and we have in both parenchyma sparing liver resections. This is a type of resection where we remove the metastases without compromising cancer-related outcomes and trying to save as much healthy parenchyma as possible. Here in this figure from Khalil and colleagues, you can see different options for non-parenchyma sparing and parenchyma sparing liver resections. However, there are some concerns when we describe laparoscopic parenchyma sparing liver resections. Those are risk of short or R1 resection margins. It is reported mainly for solitary lesions. It is challenging in the posterior superior liver segments, and this might not be suitable for large lesions. These concerns I mentioned, these three concerns we have focused on in our previous publications, which you can find in PubMed if you are interested. Today, our main focus, as I said, will be on large lesions, and therefore we identified from our laparoscopic database patients with large lesions, defined as lesions more than 5 centimeters. And we found 197 patients, and here you can see that they are mainly colorectal liver metastases, 43%, ACC 17%, cholangiocarcinoma 66%, other malignancies 13%, and benign tumors 22%. And here you can see that patients that had only 15% of patients had formal hemiapopectomies, right or left, and remaining 85% of patients had a resection of less than 3 consecutive liver segments. And here we have mainly atypical or so-called also anatomic liver resection, 53%. And here you can see that the perioperative outcomes: blood loss was 350 milliliters, operation time 145 minutes, postoperative complications rate was 23%, postoperative mortality 0.5%, and postoperative hospital stay was 3 days. R1 resection margin were 19%. This will be fantastic, or less than 1 millimeter. So, but for the current study, we focused on colorectal liver metastases, and we included this patient with that had laparoscopic parenchyma sparing, defined as resection of less than 3 consecutive liver segments, and we excluded also patient with previous liver resections. This patient with large tumors we compared to those with small colorectal liver metastasis, defined as less than 5 centimeters. So in total, we identified and included in this analysis 587 patients, 59 patients in the large tumor group, and 528 patients with colorectal liver metastases in the small tumor group. Here in this table are presented the baseline characteristics. You can see that baseline characteristics are similar besides patient age, which was higher in the large tumor group, and CA level was also higher in the large tumor group. Here you can see that the median in this table, in the median tumor size in the large tumor group was 6 centimeters, in the small tumor group 2 centimeters. The main difference in perioperative outcomes between the groups was in blood loss, which was 500 milliliters in the large tumor group and 200 milliliters in the in the small tumor group. So this blood loss difference can be explained by the bigger resection, better resection area. So there we have more bleeding possibility. So other perioperative outcomes were quite similar between groups. Besides, in the large tumor group, we had patients with simultaneous abdominal procedures, but this was not significant. We had also similar morbidity rates, 90 days mortality rates, postoperative hospital stay was also similar, such as also number of lesions, R1 resection rates, and involved resection margins. We also looked at the survival outcomes, and as you can see here, and as it was expected, in the large tumor group, we have significantly worse overall survival rates. 5-year overall survival rate in the large tumor group was 34% and 49% in the small tumor group. Besides this, we performed also univariable and multivariable Fox regression analysis to identify factors that impact survival in this cohort. So those were age as a score, CA level, presence of extrahepatic disease, liver resection, and positive lymph node status, the primary tumor. These 5 factors had independent impact on overall survival rates. So coming into conclusion, we can say that laparoscopic liver resection in total is safe, provides good surgical and oncological results, even for challenging tumors. In expert centers, based on our experience and our results, we can say that there is almost no contraindication for laparoscopic liver resections. And laparoscopic parenchyma sparing strategy for large colorectal liver metastases provides satisfactory short and long-term outcomes. Of course, there is still room for improvements, and we can perform more better parenchyma sparing liver resections with the help of improved or better planning modalities, 3D models, and navigation systems. Thank you very much for your attention. And please, if you have any questions, I'll be happy to answer to your questions and comments. Thank you very much.